Welcome. Come with me. The doctors will see you now.
Welcome back to Fast Talks with Family Docs, the podcast where we break down the latest news affecting family physicians in Oklahoma. I'm Dr. Veer Vidala, joined by my co-host.
I'm Dr. Phil Palmer. It's good to be here with you again, Veer.
Awesome to be here, sir.
And today we're going to take a close look at the 2025 legislative session and bills that will impact how family physicians practice and how patients in our state receive care. So far, the session's been a very busy one. Today was deadline day, and it's more important than ever that as family docs, we stay engaged and informed.
Yep. And to help us navigate these policy updates, we're joined by the Kari Pepper, Executive Vice President of the Oklahoma Academy of Family Physicians. Kari, thank you so much again for being here.
Oh, no, I am always happy to join you guys and talk a little advocacy.
Well, Kari, before we jump into Oklahoma, is there anything on the national level happening legislatively that we and our viewers need to be aware of?
Yeah, absolutely. So the AAFP and the OAFP are actively tracking some of these federal cuts that have been coming down. We're not exactly for sure what's going to happen, but we are closely watching cuts to Medicaid specifically and to those teaching health centers. Obviously, we know family physicians are always usually the ones that serve as the first point of contact for those Medicaid patients, and cuts to that could lead to limited access to care and an increased quality and more health disparities. And then obviously anything with teaching health centers that would lead to less family physicians on the ground would be heartbreaking, I think, for where we're at now.
Yeah, for certain, not good news on either of those issues, but maybe there's some good news in Oklahoma. So let's jump in with what's going on at our state legislature, and how about some positive things in bills that we're tracking?
Yeah, so one of the most important bills this session is House Bill 1808, the Ensuring Transparency in Prescription Drugs Prior Authorization Act. And so it's a long one.
Yeah, I know it's been a longstanding challenge for physicians and patients. How do you see this bill helping?
Yeah, this is a bill that the OFP is extremely happy about. We have worked very closely with Representative Newton on the language for this bill, and we think that this is going to help have a big impact on physicians' practices, maybe streamline the prior authorization process, make it more transparent, and some of those really key provisions include improved transparency. So insurers must publicly post their prior authorization requirements and notify physicians at least 60 days in advance. So that's the first one. Faster approval time. So on this one, insurers must process urgent medication requests within 24 hours.
Excellent. That's nice.
Non-urgent within 4 business days. And then here's the kicker, kind of like our last bill with the procedures, is that if they don't meet that timeline, those medications are automatically approved.
Oh, good.
Yeah. And then there's longer approval periods for chronic condition medication. So once you're approved for prior authorizations for chronic care medications, it will be valid for 3 years.
Okay, wow.
Yeah, so
nice.
It's really wonderful because it reduces that need for frequent renewal. So hopefully that in itself will kind of reduce some of the administrative burden for our family physicians in particular. And then continuity of care. So if a patient switches from one insurance to the next insurance, that medication that they're on will be covered for at least 60 days. So if it doesn't happen to be on the new insurance plan's formulary, there'll be time for them to get in with their physician to make those changes before their medication runs out.
How exactly is that going to be shared with the new insurance company? Because they won't have that paperwork. How will they know that the old insurance had given a prior auth and that medicine was approved?
Yeah, so I think that will fall probably. Yeah, and it will probably fall a little bit on the patient, right? So if the patient knows that they're switching insurance, they probably need to check with their physician to ensure that medication is still on that formulary. The insurance companies tell me, though, that their formularies are readily available for their patients to look at.
It's hard to access.
Yes, they're hard to find. And so that's a big portion of this, right? So one of the other really great things we were able to get out of this bill is the Oklahoma Insurance Department is going to host one page on their website that's going to have all the formularies for each of the insurance carriers on it. So
That'll be great.
not only will it be wonderful for you as a physician, but you could point your patients to that website as well, and they can look up their formulary and not have to dig through a website to try to find where it is. So that one's really great. Another one is stronger oversight. So prior authorization denials must be reviewed by a qualified physician, pharmacist, or specialist rather than like an automated system. So that just kind of gets it going back to that peer-to-peer review. So you're not worrying if it was a computer that denied or reviewed your process.
Yeah, well, this prior auth bill has a lot of significant improvements for practice. It's exciting to see that coming along because delays really cause so much problem, and especially in managing chronic conditions.
Yeah, and there's one other big one that I think will be extremely helpful to our physicians, and that is, say you get a denial for a medication. A lot of the time, the physician has no idea what medicine after that they can prescribe, right?
Yeah.
And so now the insurance companies are going to have to provide you on that denial letter alternative medications that fall within that physician or that patient's formulary. So it makes it easier for the physician to say, okay, now I can prescribe this one and I know it's covered.
Yeah.
So I think that will be a huge help.
Yeah, that'll be
huge benefit,
saving us a
definitely.
lot of time for sure. That way we're not just guessing.
Yes.
You know?
So we're really, really excited about that one because we really do think for primary care, it's going to make a big difference for our providers because I know you take care of a ton of chronic care patients, and I hear prescriptions are a big thing on your to-do list. So hopefully that will be a big help.
Yeah, I've got a stack of prior auths to do when I get home. Anyway, so shifting gears, another bill receiving strong support is SB875, which focuses on protecting primary care investment. Kari, you care to talk about that more?
Yeah, I think you guys probably have heard me talk about it a ton, but in previous legislative sessions, Oklahoma secured that commitment from the legislature to mandate 11% of the overall Medicaid spend be directed towards primary care. This bill really just strengthens that investment. So it talks about reinforcing accountability for those funds that were allocated, ensuring the transparency, and then putting some sort of teeth in place to make it sure that they meet it. Both of those bills that we've just talked about have passed through the committees. And they're both just awaiting floor to be heard on the floor. So they're making good traction. And so we're really excited to continue to watch those move forward as well.
Yeah, that's great. And there's plenty of research showing that that type of investment in primary care absolutely leads to better health for the communities when there's a bigger spend on primary care things. So that funding is going to be great for Oklahoma's healthcare system long term.
Yeah, and I think that's the important part of making sure that they do reach the 11%, right? And that investment, because we want to be able to show that the money that they invested in primary care is making a difference on health outcomes and on patients' life. But the only way you're going to be able to see that impact is if the money is actually spent on those primary care services. So
Putting a little focus on primary prevention too, and not just management of chronic diseases.
Right.
Yeah. Well, I mean, I already asked this about this next bill with you guys multiple times already today, but I want to shift to SB 1050, which addresses insurance clawbacks, and it's something that I think some providers may not know about. So, Kari, do you mind, dwelling into more what that means and what that bill looks like?
Yeah, absolutely. So this is another one that's passed through the committees, and it'll just be awaiting a floor hearing. But clawbacks occur when an insurance company retroactively denies a payment for a service that it already approved and paid for. So physicians may be required to return those payments, and sometimes it's months, even years later. And obviously, you can imagine the strain that could put on a physician's practice.
Definitely.
So this bill in particular it limits how far back the insurance can go to be able to seek that repayment. And then it just makes sure that there's fair notice given on any of the clawback when it occurs. And it just provides more stability for medical practices, knowing okay, it can only be within this time range versus years down the road.
Yes, I guess those solo practices or independent private practice family docs could be really affected by this. And they don't have that support system from the huge corporate systems.
You need some degree of financial stability for those smaller practices to succeed.
Yeah, if you think about it, it'd be like getting a paycheck and then like a year later, somebody being like, oh, well, I'd like to take some of that back.
Yeah, that was right.
Yeah. And so I think when you really think about those small practices who are paying for staff, or maybe they're really small staffed, it makes a big impact when you start messing with the bottom line of what they can use for their services. So I think it could have a big impact if we were able to shorten that length of time that they can come back for those clawbacks.
Definitely a positive.
That would be really helppful. Okay, we talked about all the good news. All right, Kari, give us the bad news. What are some bills of concerns?
Yeah, so obviously we're the biggest bills. I think this is, I would call it the year of scope.
Yeah.
It seems like every time I turn around, there's another scope bill that we are watching. And so one that we're closely monitoring is Senate Bill 741. That's a pharmacy test and treat bill. And right now the title's been stricken, meaning changes are likely. So it looks like there will probably be more negotiations, more conversations had on that. It's still awaiting a floor hearing. And we'll need to review any like amendments that get added or any new language, just to make sure, prioritizes patient safety. Obviously, it's not one that we probably want to go through all the way anyways, but if it does go through, we want to make sure it has the best protections in place for patients.
So you mentioned test and treat. What does that mean? What does that look like for pharmacists there?
Yeah, so test and treat it gives the pharmacist the ability to test and treat or prescribe medication for like a small factor or a small scope of different things. So we're looking at like flu.
Kind of a limited panel.
Yeah, limited. So flu, COVID, strep. The bill does say strep for 8 and above. So they can't do 8 and below.
Okay.
And several.
Urgent care stuff.
Yeah. And several other things. So one of the biggest concerns, I think, is like, well, what does test and treat actually mean? Mm-hmm. And what are they going to be doing? Are they going to be doing a full workup? Are they going to do vitals? Are they going to be recording those vitals? Are they going to be talking to the physician who takes care of that patient on a regular basis? That's not really defined. It just says that they'll be able to test and treat for a certain amount of those limited panels. And I think that's the the part that makes people nervous, right? Is like, what's the quality of care that they're going to actually be getting? And we know that flu, just right now in this season alone, like flu and RSV and COVID, like those are all pretty severe cases that are happening right now. So not having that physician follow up or that physician point of contact to know like, okay, is this just a cough or is this actually something more severe?
Yeah, that's a big area of concern.
Yeah.
It's so interesting because they have access to their history, allergies. We don't give Tamiflu usually after day 1. There's no benefit. And then antibiotic stewardship's a big deal too. You just can't throw Z-Paks on everybody. That's why there's so many resistance right now. It's an interesting bill.
Yeah.
Yeah. Kari, one of the other scope concerns this year is House Bill 2051, which proposes creating something called an assistant physician, which would be a new role, a new type of supervised licensure for medical students who didn't match in a residency position. Can you tell us some about that?
Well, yeah, I was actually going to kick it back to you because Dr. Palmer and I have worked on this bill. I think it was introduced last year.
Yes.
Different language last year than it is this year. But still, I think concerning to us when it comes to just expanding and adding another mid-level into the system. And I think, Dr. Palmer, you probably have a lot more information and impact on this one and what you think it could possibly do. I know you've talked with the bill author several times about your concern. So I'll let you take the lead on this one.
Well, I think when we look at this particular bill, when medical students graduate, they cannot be fully licensed in the state of Oklahoma. They still have to take the final third portion of the United States medical licensure exam and pass it before they can get an unrestricted license. And so while they're awaiting that, they're continuing to get training in an accredited residency program with required structures for supervision in order to make sure the care they're delivering to patients is safe and appropriate. This bill would allow the formation of pop-up shops, so to speak, where these students can find a doc practicing in the state who would agree to supervise them, and they would collaborate together to deliver care within the state in what specialty and what level of care and what level of supervision. At some point, somebody in the future with the medical licensure board will make some decisions about that. But it's really creating this, in my opinion, this wild, wild west kind of frontier of medicine that doesn't seem to be necessary. I know in times past last year, the push was, well, this will help meet a primary care need in rural parts of the state. But we always have primary care residency training slots open in family medicine and internal medicine and pediatrics. So if people want to go into primary care, they can without this bill needing to exist. And so there are a lot of concerns like that. There, I think, are maybe 8 states in the nation who have some sort of bill along these lines. And I've yet to hear from one of those states that are happy with the bill and happy with the results for care. There have been a lot of states that have had significant concerns with the quality of care that's being delivered by some of these assistant physicians due to inadequate supervision. And in fact, last week or the week before, it was announced in Missouri that collaborating supervising physician based on Missouri's version of this law was fined $750,000 and is facing 3 years in prison. And then there are several other people that were involved in this as well that are looking at fines and prison time. And so it's really, we don't need that in the state of Oklahoma. There's no positives, in my opinion, and a great deal of negatives for the health and welfare of our citizens.
Yeah, absolutely. I think you hit it right on, because if we create another one, right, we also know that like once it's what this bill, I think states 2 years, they have 2 years to match. Then the next thing you know, it'll be 4 years, and then it'll be 6 years. And I know one of the other things that you've talked about is like, when does it take away the need for residency programs altogether? Like when does the residency program become obsolete because you could just not do it? You could go get your assistant physician. And so I think when we're looking at it, it's with any mid-level provider, right? Everything that we're looking at is patient protections, and how do we protect the patient so that the patient's getting the best level of care? And I think going back to that, we're looking like, okay, even these students who've gone through med school still need the additional training, and they need the time with those patients to be able to effectively treat on their own.
Yeah, it's fascinating to hear, because even if you look at, if they're looking into other specialties and they're coming into primary care as a backup, I'm going back and looking at these rotations, and maybe family medicine is the 1 month or 4 weeks at OU that you do outpatient care. The rest of it's inpatient, right? Yeah. And so it's very interesting when we think about, first rule, we take an oath to do no harm. And to be able to come out there and just be like, I am ready to take on this without knowing what level of supervision I have gives me a lot of anxiety. So I get it. Thank you, Kari, Dr. Plummer, for helping us understand why we need to watch this bill more closely. But as we talk about this, scope of practice expansion's always been a topic. Kari, what can you talk about key concerns that we have this year?
Yeah, so I think we'll go on to a couple of the other ones that we're watching, which is House Bill 2298 and House Bill 2584. So these are both physician independent. They're independent prescribing bills that would make it to where a physician did not need to supervise for both PAs and APRN. So 2298 is the APRN expansion bill, and then 2584 is the PA bill. And so we are just watching that because both of those bills also include prescribing Schedule IIs. And, Oklahoma's had a big opioid issue, and we have made a lot of great strides in the past couple of years on this issue specifically.
For sure.
So anytime that something starts expanding and giving more access to people prescribing Schedule IIs, a red flag goes up for us. And obviously we think that mid-levels are an incredible part of the team, right? But we still, as family physicians, believe in that physician-led team model.
Still a team,
Yeah.
right.
And so we're watching both of those. So both of those also passed out of committee and are awaiting floor or are waiting to be heard on the floor. If you guys remember, we had talked in the last episode about House Bill 1812, which was the one that we introduced with Newton again. And it kind of set some standards. So we had heard a lot of complaints in the past couple of years of like, well, this level of supervision isn't what I expected or not good enough.
Right.
And physicians are charging too much money and they're not available when I need them. And so in that, we thought like, look, how do we make it to where we're policing ourselves, right? Like, how are we going to say like, hey, we need to be better, or we need to set some standards to ensure that everybody is providing that same standard of supervision across the board. And what does that look like? And let's make sure nobody is charging an outrageous amount for this. And so 1812 was the bill that we put together with Newton to address all of those concerns, as well as like putting a list of available supervising physicians on the board websites. And so we worked on that. 2298, which is the APRN bill, kind of swallowed it up now. So 1812 portions of that are now in 2298. So it is, I mean, there are some great things. So some of the things that we worked on specifically are in House Bill 2298, but we're going to continue to watch this bill as it moves along and offer some more suggestions, hopefully, as it moves, just to make sure, again, going back to that patient protection and ensuring that we are really taking care and making sure that education, that continuing education is there, that there's like a good amount of physician supervision, and there are some good processes and rules in place before this happens or before it takes place.
So a lot could definitely change because we've just kind of finished deadline today to get out of the hearing committees, and now bills that pass that deadline will go to the floor of the House or the Senate for further discussion and amendments and hearings.
Yeah, so they'll do that, and then they'll flip houses, and then they'll have to go through the process all over again. So we will be watching, and hopefully that those bills that we have worked so hard on will get those floor hearings. And get, last year we got 0 no votes on the prior authorization reform bill. So hopeful for zero no votes again. Right. But it should start as soon as Monday. So that they should start rolling again on as soon as Monday.
Great.
Fantastic. Kari, before we wrap up, what can we as physicians do to stay involved in this legislative process?
Yeah, absolutely. I think one of the most important things is just connecting and contacting your legislators. I think I talk about it all the time. It doesn't need to be a lot. It can be a simple email, a phone call. Most of them are pretty good about giving their phone numbers out if you go and meet with them, especially if you mention that you're a physician constituent in their area. They love to hear from you, and they love to hear your voice. And I think the other things that you can do is make sure you sign up for the OAFP advocacy alerts and follow along with us, not only through those emails, because I know sometimes those get lost in your inboxes, but also on social media and our podcast, right? We're keeping people up to date, trying to in a timely fashion. But we provide updates through the email, through social media, on action items, alerts that we need. And so if we do send one of those, it's probably because we really do need the voice of the physician on that issue. We had a really incredible turnout at Medicine Day on Tuesday. And I was so impressed at the number of students and residents that rolled out.
Yeah.
It was really incredible to see that. And I say it all the time. I'm like, this group of residents and students seems so engaged in the advocacy portion of it, but it was really great to see them kind of doing that. And so just carrying that momentum forward and maybe like taking a book from their page of like activating and showing up at the Capitol would be wonderful. We'd love to have you. We know it's hard to get away from your clinic. So, but if you do have a chance, you can give myself a call. I'm happy to introduce you, walk you around, those kind of things as well.
Well, Kari, thanks for coming. You know, these conversations really do make a huge difference in educating people, and we're grateful for what you. And then I want to give a shout out to Dawn as well.
Yeah.
The OAFP is obvious. Thank you
She's
for
amazing.
the time and effort you guys have been putting in over the last several weeks, especially.
Yeah, absolutely. Dawn and I spend, I don't know how much time on the phone together and by text, but I just want to say, like, they really do rely on our physicians' input. They know you're the experts. I know a lot of the times people will say to me like, "Oh, well, I'm a physician. I'm not really into the advocacy portion," but they want to know from you. They want to know how it impacts your practice and how it impacts your patients and conversations. You guys are great at conversations, so that's all that they want from you. And so I always say that, and I always say when family medicine leads, Oklahoma wins. And I think Sean Martin, we were just at Multi-State, gave a really good reminder. And he said, you don't ever ask for the environment. So like we don't know what we're up against, because it can get kind of disheartening sometimes when you're working really hard and these bills don't pass. But he just reminded us, like, you didn't ask for the environment, but you did ask for the mission. So choose the mission. And it just was kind of a really great reminder of like, okay, this is why we're doing what we do every day. And so if you are feeling discouraged, I would just remind you, like, just because you didn't choose the environment, you chose the mission. And so to keep it up, because it's really impactful.
Yeah, it's wonderful, Kari. It's so inspiring. And I know we're just seeing patients all day, but, Dr. Franklin put it really nicely at one of our old podcasts: when you have opportunity to speak and desire to speak, speak. And I think that's what we really need to do. Thank you again for walking us through all the legislative updates today. We appreciate it.
Yeah, and I will, myself or Don will be back soon. And this changes very quickly, so definitely follow along with us on social media for updates.
Yeah, and thank you, listeners, for joining us. And if you found this episode helpful, then be sure to share it with your colleagues and encourage them to subscribe to our podcast. We'll continue to keep you updated as the legislative session progresses.
And follow us on Instagram, because that's where I get all my updates, and it's really helpful. Okay. And that's it, guys. Thanks for joining us. We'll see you next time. Fast Talks with Family Docs.
Bye.
Thank you for joining us today. The doctors would like to see you back for another check-in. Please choose to follow our podcast, and you will automatically be notified when it's time for your next appointment.